Good morning. My name is Dr. Katie Arendt. I'm an obstetric anesthesiologist at the Mayo Clinic, and I was asked by Dr. Hopf to speak to you today a little bit about my job and OB anesthesia as a career for the Foundation of Anesthesia Education and Research. Congratulations for you all on all of your research positions this summer. And I'm sorry that things may not be going as exactly as you planned with coronavirus, but hopefully we'll get through this soon. Okay, let me switch my sides here. So what Dr. Hopf asked is to expose you to various different leaders and role models in anesthesia and anesthesia research, to introduce you to some of the important questions, and to highlight successful approaches to building a successful career in academic anesthesia. So let me introduce you to me. I was born and raised in a small town in northern Michigan, Petoskey, Michigan. I did my undergraduate at Ohio Wesleyan University in central Ohio, and then I came to Mayo Medical School in 1998. I did my internship in anesthesia residency at Mayo Clinic. I had two daughters during residency, one in 2003, who's currently 16, and another in 2006, who is 14. And then I did an OB anesthesia fellowship at the Brigham and Women's Hospital in Boston, came back on staff at Mayo Clinic in Rochester, Minnesota, December 2008, and then had my third child in 2010. Currently, I am a division chair. The Mayo Clinic has 172 anesthesiologists, 335 nurse anesthetists. We cover 206 anesthetizing locations. We're broken up into 7 divisions, and I'm chair of one of those divisions, and then I'm also the associate practice chair of the department, and I am the program director of the Mayo Clinic OB Anesthesia Fellowship. I have been on the board of directors for SOAP up until this July, at which point I will step off for a couple of years here and do some work in the committees of SOAP. I have lots of support systems. I have an amazing husband and amazing group of colleagues. When my kids were little, I had parents and in-laws that were helping tons with our kids. My other support is I like to jog out on trails and get muddy. And then I get lots of therapy from friends and colleagues. Now that my girls are adolescents, I need lots of that. All right, so what's my passion? My passion is OB anesthesia. I absolutely love it. The field has given me far more than I could ever give back to it. What is OB anesthesia? So OB anesthesia is 3 topics, 3 areas I split it out to. Number 1 is maternal safety during childbirth. Number 2 is fetal and newborn safety during childbirth. And number 3 is maternal satisfaction. All right, so we obviously, maternal safety, I'm going to go more into that, but fetal and newborn safety in childbirth, things that we give the mother pass on to the baby, and there are many interventions that can happen and things that can happen to a mother in childbirth that require the baby to be delivered very quickly, i.e. cesarean delivery, for which anesthesia is required. That ability to provide rapid anesthetizing conditions or surgical conditions for a mother is a large part of what we do. So we're always ready for an emergency. OB anesthesia does have a bit of the type of person that likes it, tends to like adrenaline. It's a super fun place to be. And it's sometimes scary. And then finally, maternal satisfaction, to talk a little bit about that. Maternal satisfaction is things like labor analgesia. Now, sometimes it seems as if the world of midwifery and people desiring in various products promoting natural childbirth, or this idea of unmedicated childbirth being the most natural childbirth, that is what those groups have said, oh, they're the ones in charge of maternal satisfaction. But I really feel that maternal satisfaction has a lot for many women to do with pain control, if they so choose, if they find that to be a more empowering form of childbirth. And it also has a lot to do with knowing that they and their baby are safe, so that if they do need to deliver quickly, they can do that in a way that is comfortable, and that's us. So maternal satisfaction, although it's number 3 on our list of priorities, is still a very important priority of obstetric anesthesia. So what I particularly like to focus on in my area of, of clinical research is maternal safety in childbirth. That to me feels extremely paramount, especially lately. So when you look at maternal safety in childbirth, you think, well, geez, it's childbirth. People have been doing it for millions of years. Of course it's safe. No, not necessarily. In 2017, there were actually 295,000 maternal deaths in the world. When you look at this slide here, you can see that maternal mortality ratio is where is highest where the darker areas are, which includes sub-Saharan Africa and Southeast Asia, and some darker areas in South America as well. So you can see in Western Europe, and the United States, North America, you can see that the maternal mortality ratio looks more promising. But actually, the maternal mortality in the United States is increasing, and it's been called an American crisis, and there's a lot of work that needs to be done. In fact, the United States has some of the worst rate of maternal deaths in all of the developed world. And that rate is only increasing. You can see here that the United States has a maternal mortality ratio as high as 26, and it's only been going up since 1990, while other developed nations have continued to decline. So why is this an important area of research? Why is this an important thing for OB anesthesiologists to learn about, and all anesthesiologists to learn about, and all people to learn about? Well, I really feel passionate about the fact that when we lose mothers, we lose one of the most important components of our civilization and culture. Unfortunately, in the United States, there is a huge component of racial disparities when it comes to maternal mortality. And when you take the effect of age and you combine that to race, when we look at the years from 2011 to 2013, you'll see that at less than 20 years of age, there is some difference between non-Hispanic white and non-Hispanic Black regarding maternal mortality ratios. But as you get up above the age of 40, you can see how these risk factors come together to create an astronomically increased risk of maternal mortality for non-Hispanic Black women over the age of 40, resulting in a maternal mortality ratio that's as high as any developed nation or undeveloped nation, or underdeveloped nation, excuse me, for women who are Black over the age of 40 delivering in the United States. We have a lot to do for Black mothers in the US, and this is an area of a significant research, and there's many people that are specifically working on this from areas of epidemiology as well as racial equity. Stepping back and again going back to this idea of maternal mortality and why it's so important. If you look at overall, just to make sure you leave this part of my talk understanding kind of some important concepts, is one, low-income countries do comprise about 99% of maternal death, with about 1 out of every 150 women that are born having a lifetime risk of maternal mortality. So you take 150 girls, they're born, 1 of them will die in childbirth. The leading cause worldwide is hemorrhage. And if you take hemorrhage and preeclampsia, that takes pretty much 50% of all deaths. High-income countries, out of every about 5,000 girls that are born, 1 of them will die as a result of pregnancy and child risk. This is typically because of high-risk populations and pre-existing conditions. The pre-existing medical condition that I specifically focus on is cardiovascular disease. That is sort of what I do research in, and that is, you can see here when you look at women between the years of 1987 and 2013, you can see that as hemorrhage declined as the leading cause of pregnancy-related deaths in the United States, what started to go up was cardiovascular conditions comprising 15% and cardiomyopathy 11%, so a total of about 25–26% of deaths in the United States are a result of maternal deaths are a result of cardiovascular conditions. So right now, these 2 areas are really an area of research. So What do? I do a lot of retrospective type work. We're looking at these women with high-risk congenital heart disease, high-risk acquired heart disease, and reporting on their outcomes and how we take care of them as anesthesiologists. But that's not the only question in OB anesthesia. In fact, there are tons and tons and tons of questions that need to be asked in obstetric anesthesia. Maternal safety and childbirth is a huge area of research, from hemorrhage, reducing death from hemorrhage, preeclampsia, sepsis, maternal stroke, amniotic fluid embolism, thromboembolic disease, anesthetic complications, studies of the maternal airway, cardiac arrest, bringing women back, trauma, neurosurgery, CV surgery in pregnancy, appropriate anesthetic techniques, and of course, ARDS in pregnancy. There's much work that right now needs to be done on the effect of proning in pregnancy in our patients with ARDS. Lots of questions when it comes to fetal and newborn safety in obstetric anesthesia. How vasopressors affect the uteroplacental unit, how anesthetics or analgesics affect the newborn. Lots of work to do there. Maternal fever is another area that is, and how that affects newborns is another area of OB anesthesia research as well. And finally, maternal satisfaction, optimal labor analgesic techniques, cesarean anesthesia techniques, maternal well-being, postpartum depression, the effects of good pain control on postpartum depression. There's a colleague named Grace Lim who's doing a ton of work in there. Of course, empowering childbirth experiences are one of the things that OB anesthesiologists are always trying to work through. So as you look at obstetric anesthesia, the field is wide open. It is difficult to do randomized controlled trials in anesthesia. So there's lots of different ways that we have to come at, especially our research in maternal safety. All right, so I'm a clinical researcher. I'm a clinician. I write, I present, I teach on keeping women safe in childbirth. I publish mainly retrospective reviews and some clinical or randomized controlled trials, but I don't do lab work. I do a lot of hands-on care of women. I also work to try to educate both other clinicians as well as learners. I love my work. I can't think of anything else that I would rather be doing. I think deep down I am an absolute feminist at my core, and I really believe that the care that we give women at the birth of their children is a pivotal time in their life as to whether or not a woman is going to be able to change her life as well as that as her child. Many women come into pregnancy and childbirth sort of backwards, maybe not even planned. But if we can give them a sense of control during their childbirth experience, I really believe that we can start that woman out on a good foot. Likewise, for the rest of her life as well as her child's life. Likewise, if a woman has a traumatizing experience during childbirth or even a near-death experience, or if a child, God forbid, loses their mother, this is a complete devastation on that family. I feel much purpose if you can't tell me. So successful approaches to building a career. If I were to tell you one thing, find your passion. Find something that you feel absolutely strongly about. You say, you know what, this area really matters to me. Find your people. Whether that be at your institution or outside of your institution. My people, a lot of my people tend to be in the Society of Obstetric Anesthesia and Perinatology, or SOAP. It is an amazing society. They feel like family to me. I call them, I have mentors all over the country, lots of connections. Be deliberate with those relationships as you're building your career, because as you go different places, make sure to have a cup of coffee with somebody you haven't seen for a while, and be sure that you are not only seeking mentors, but you're also seeking to mentor somebody that's right behind you. That is a big cycle that you get in, and it becomes habit. You learn how to be a good mentor. At the same time, you're learning how to be a good mentee because you're seeing somebody else mentor from you. So getting within that circle and feeding as much into it as you're taking out is super important. Another recommendation I have is to write every day you possibly can. Even though you're always, as a clinician, you're always squeezing your research in, come an hour early, stay an hour late, work to squeeze it in. where you can. You're squeezing everything in your life, especially as a parent. But this is, I have a very existential sort of way of viewing all of this kind of plates I keep spinning with, being a mother, a wife, a friend, a daughter, a clinician, a researcher. Make each choice the best you can each day, but make sure that you recognize that what you choose today may not be what you choose tomorrow. So make each choice as a passion, but don't feel that you need to get labeled or kind of stuck in a pigeonhole of saying, I am a working mom, or I am a bad mom, or I am a good mom, or I am a researcher, or I am a this. You can just flow with where your passions are, in my opinion. Just put some discipline within your life, and make sure that you are making each choice the best you can. There are times in your life where you're going to have to prioritize a particular child, and then that child will need you to back off a little bit, and then you can prioritize some research, and it's ebbing and flowing like this all the time. Finally, there are hard times. I have to say the last couple months, as a leader, as a parent, as somebody that was concerned about the safety at times of the people to which I'm assigning work in my workplace, it was really hard. And I want to remind people, when you're going through times like that, just keep going. Don't stop. Just keep going. Put your head down. Do the best you can each day. Keep a positive attitude, but just keep swimming. I think that will be true for all of you as you move through your career, because as I look back on my own, I know that I've had good times and I've had hard times, but overall, I am just feel so blessed to be an obstetric anesthesiologist. Thanks for listening to me.